coming up. So all of those factors were propensity matched, which means that the percentages between the two groups were almost identical. So that's a way of trying to get around potential biases by the fact that this was a retrospective cohort study as opposed to being a prospective randomized controlled trial. So there's fundamentally going to be more biases in a retrospective observational type study compared with a prospective experimental design study. But one way that the authors tried to minimize those biases was by doing this propensity matching so that all of these confounders that they prospectively hypothesized could be confounders were equal between the two groups. Hello, and welcome to the next installment of Risfeld Neurology Education, a not-for-profit, free open access project with a philosophical touch exploring all areas of clinical neurology, meant for medical students through to neurologists and any health professionals caring for patients with neurological conditions. I'm your host, Thomas Risfeld, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. Today, we've got an episode titled SGLT2 Inhibitors and Reduced Risk of Parkinson's Disease and Dementia Journal Club. And it falls within a few different series. It falls within the Parkinson's Disease and Movement Disorders series, the Alzheimer's Disease and Dementia series, and the Journal Club series. And I'm filming again on a weekend, so I'm in a casual t-shirt, and this is one of my favorite works by French artist Guy Belleau, spelt Billout. I hope I pronounced that correctly. So again, this episode is a Journal Club episode. I'm doing a few of these in a row recently, and that's because I've prepared this content recently and I want to get it out in time before it becomes outdated, because then it will have reduced value. And I did want to have some content that was more applicable to some of the more senior audience members, so neurology trainees and neurologists. But I do anticipate that this will be very useful for more junior audience members as well, both from a clinical perspective, so learning about the potential role of what anti-diabetic medication you may use in the treatment of diabetes in terms of flow-on effects that may have down the track for neurological purposes, but also as a constructive exercise of how to critically evaluate a research paper in medicine to try and determine its strengths, its weaknesses, and if so, how it can be applied to our clinical practice. And as always, a legal disclaimer: the content of this episode is for educational purposes only, and also any post-publication corrections that I may come across will be included in the video and audio podcast descriptions. So let's dive into it. This paper was published last year, so in 2024, in Neurology, and it's titled SGLT2 Inhibitor Use and Risk of Dementia and Parkinson's Disease Among Patients with Type 2 Diabetes, and it was authored by Kim et al. So if you're watching the video version of the episode, you can see the abstract on the screen here, but I won't read it out because we're going to go through the paper in detail now. So the introduction, let's set the scene. So dementia, including Alzheimer's disease and vascular dementia and Parkinson's disease, are becoming increasingly prevalent owing to an increasing lifespan. And type 2 diabetes is a well-established risk factor for cognitive impairment and can exacerbate cerebrovascular damage and neurodegenerative processes. Type 2 diabetes and neurodegenerative processes share some core pathological features, including central nervous system insulin resistance and reduced cerebral glucose metabolism. There have been some previous studies that have looked at anti-diabetic drugs and potentially promising benefits of reducing the risk of neurodegenerative diseases, although with a low overall quality of evidence, the authors explain. Now, SGLT2 inhibitors, or sodium glucose cotransporter 2 inhibitors, inhibit glucose uptake in the renal proximal tubule, therefore inducing glycosuria and therefore reducing systemic hyperglycemia. So basically, you're urinating out the sugar so that it doesn't stay in your blood and get deposited in your end organs. SGLT2 inhibitors have also demonstrated benefit not just for diabetes, but also for cardiac and renal protection, possibly attributable to improvements in mitochondrial and autophagocytic function and upregulation of ketogenesis, from systemic stimulation of low energy metabolic sensory pathways by urinary glucose losses. It has been hypothesized that this cardiorenal benefit may extend to the brain as well, given that both mitochondrial and lysosomal dysfunction are central in a number of neurodegenerative diseases, and ketogenesis may also be beneficial in addition to the benefit that it has on the underlying type 2 diabetes mellitus and on any associated hypertension. So, how did the authors of this study go about trying to answer this question? So their question is, could SGLT2 inhibitors used for type 2 diabetes mellitus also have a flow-on benefit in terms of being brain protective and therefore having beneficial outcomes in terms of reduced prevalence of various dementias and of Parkinson's disease? So what were their data sources? It was a Korean-based study. So it was sourced from the Korean National Health Information Database, which is a government-affiliated insurer managing the mandatory insurance system, which covers the entire South Korean population. The study protocol was prospectively approved by a university institutional review board, and informed consent was waived because this was a retrospective study with completely anonymized data. So it was a retrospective observational study. The participants were greater than or equal to 40 years of age, and this is given the rarity of neurodegenerative diseases prior to this age. They had to have a diagnosis of type 2 diabetes mellitus, and they needed to have been treated with anti-diabetic agents for at least 90 days or more. And it was collected between the years of 2014 and 2019. Exclusion criteria were pre-existing neurodegenerative disease diagnosis, and that was defined as a dementia of any form, Parkinson's disease or Huntington's disease, cancer, or GLP-1 agonist use. This last one surprised me a little. It wasn't immediately obvious. In fact, it still isn't obvious to me why that was included as an exclusion criterion. Perhaps you can comment if you have any ideas in regards to this. So, what were the authors actually looking at? What were their primary outcomes? Well, principally, they wanted to know about the development of Alzheimer's disease, vascular dementia, or Parkinson's disease. So technically, they had three separate primary outcomes. Their secondary outcomes were the development of all-cause dementia, so Alzheimer's disease, vascular dementia, and all other forms of dementia, and also a composite of both all-cause dementia and Parkinson's disease put together as one number. The SGLT2 inhibitors that were evaluated were dapagliflozin, empagliflozin, so they're the two that are available in Australia, and also etugliflozin and ipragliflozin. The groups were defined in these ways. So the SGLT2 inhibitor group had to, of course, be on an SGLT2 inhibitor, and they didn't have to be, but they could also be on other oral or injectable anti-diabetic agents. So for instance, metformin, sulfonylureas, DPP-4 inhibitors, insulin, and also less commonly, meglitinides and, I can never pronounce this word, thiazolidiniones. The control group had to be on an oral anti-hyperglycemic agent, but not on an SGLT2 inhibitor. And then, of course, they could also be on insulin. And it's important to note that insulin is associated with a higher incidence of dementia, so insulin use was balanced between the two groups. There are a number of covariates that were analyzed, so they looked at socio-demographic factors like age, sex, region of residence, whether that be rural or urban, city-based or metropolitan, their income quartiles. They looked at microvascular complications of diabetes, so nephropathy, neuropathy, retinopathy, and macrovascular complications of diabetes, so cardiovascular, peripheral vascular, and cerebrovascular stroke complications. They looked at other comorbidities. They looked at other medications, including antidepressants and anticonvulsants, which may affect the risk of neurodegenerative disorders. Although I wasn't entirely sure quite what they were alluding to here. Perhaps they were referring to antipsychotic use, so dopamine antagonists and the risk of developing extrapyramidal features, which can be a mimic of Parkinson's disease and primary extrapyramidal conditions, or perhaps they were alluding to depression being a risk factor for the development of dementia and patients being on antidepressants, therefore having dementia. Maybe that's what they were getting at there. Then medication use was determined by pharmacy prescription dispensing. So that means that if a patient just wasn't taking their medications, they weren't being dispensed in the first place, then they weren't incorrectly counted as taking the medication. So it was based on them actually going to the pharmacy and the medication being dispensed. And their overall comorbidity burden was also measured, and it was scored according to the CCI, the Charlson Comorbidity Index. Statistical analysis, how was that performed? So they did both independent sample t-tests and chi-squared tests. They also did propensity score matching PSM. So that's balancing anticipated confounding factors between the two groups. For example, insulin use. So the insulin was balanced between the two groups. This was performed before the final selection of study participants so as to reduce biases, including selection bias in this fundamentally observational study. The incidence rates of the outcome measures were reported as events per 10,000 person years of follow-up, and then a cumulative incidence was estimated with Kaplan-Meier survival curves. Both hazard ratios and 95% confidence intervals were then determined through Cox analysis, and the lag time of 6 months was used to account for latency time and to reduce reverse causality. So in other words, only cases of dementia and Parkinson's disease that occurred more than about 6 months or about 180 days after the date of inclusion into the study were included. So that means if you're on your SGLT2 inhibitor or you're on other agents but not your SGLT2 inhibitor and you're included in the study at day 1 and then you're diagnosed with Alzheimer's disease 10 days later, it's really not feasible or plausible that 10 days of inclusion on the study and 10 days of use of those medications was the cause of the Alzheimer's disease. That would have been by chance. I'm not sure about the reverse causality. I'm not sure how it would be that plausible that someone with dementia would then have a need to go on an anti-diabetic medication. But in any case, I think it's sensible that the authors did include this lag time in their methods. Further points on the statistical analysis, they did do sensitivity analyses to test how robust the findings were. And this was done via analyzing the risk of dementia and Parkinson's disease, which may have been associated with cumulative SGLT2 use over 6 to 24 months to assess as to whether there was any dose effect present. So that's saying, was SGLT2 inhibitor use over 6 months having less of an effect on dementia risk and Parkinson's disease risk compared with use over 24 months? So was there a dose effect seen? They also compared dementia and Parkinson's disease risk in patients on SGLT2 inhibitors who were not on thiazolidinodiones versus those who were on that other class of medication that I can never pronounce as a reference group within the same cohort, given that there is some evidence that thiazolidinodiones also have some positive results for neurodegenerative diseases. They did limit study participants to those who had completed the baseline national health screening test within 2 years of the inclusion into the study, so as to strengthen the data richness so that they didn't have missing data to limit their assessment. And they also limited their inclusion to patients who had had at least one additional national health screening test after indexing. And this data was then used for the propensity score matching that I mentioned earlier. And they also attempted to evaluate for any synergistic effects of metformin plus an SGLT2I by comparing those patients with patients who were using other oral anti-hyperglycemic agents but not using metformin, and they looked at those in both groups. So I hope that makes sense. They wanted to know, does the combination of metformin and an SGLT2I have any additional effect on the rate of Parkinson's disease or dementias? They then performed subgroup analyses according to various factors, which I'll talk about in the results section to save time. And in terms of their software that they use both SAS and R for their data analysis, which I thought was a bit odd. Why would you use both? Normally you just choose one or the other, but each to their own, I suppose. The study was funded by national grants and by university grants. So importantly, it was not funded by a drug company that sponsors an SGLT2I, for instance. A couple of the authors did have disclosures of receiving grants from various drug companies, but that's very standard in academic neurology and academic medicine generally. Results. This is what you've all been waiting for. So who was included in the study and what did the study find? So there were heaps and heaps and heaps of patients who were identified. In fact, we're talking about 1 million patients who were identified as being potentially eligible for inclusion. So there were 227,000 patients who were determined as being eligible for the SGLT2I group, and there were 778,000 patients who were identified as being eligible for inclusion in the non-SGLT2I group, the control group. However, what they did was they did this propensity score matching so that, for instance, the same amount of patients in both groups were on versus not on insulin and some of those other factors they did propensity score matching for. And then they deliberately created pairs of patients between those propensity matchings within the control group and the intervention group. And what they ended up with was 179,000 matched pairs of participants. So in total, there were almost 360,000 participants in the study. The variables that were included in the matching is included in table 1, which I'll talk to shortly, but I'm going to have to keep it a bit brief because it was a 2-page table printed in A4 print and it takes 4 slides of the presentation. So I'm not going to read every number on these slides, but just so that you know what characteristics they did this propensity matching for in their determining matched pairs for inclusion in the study. The factors that they looked at were age, mean age, sex, so male and female, region as being either rural, city-based, or metropolitan. I assume metropolitan means big city. Their income quartile, 1 through 4. Their comorbidity index, the CCI score of being 0, 1, or greater than or equal to 2. Their diabetic complications, so nephropathy, neuropathy, retinopathy, comorbidities including cardiovascular disease, stroke, transient ischemic attack, heart failure, arrhythmia, hypertension, dyslipidemia, COPD/asthma, depression, a history of diabetic ketoacidosis or hyperglycemic hyperosmolar state, or formerly known as HONC, hypoglycemic episodes, diabetic feet, peripheral vascular disease, chronic liver disease, head injuries, and these were all propensity matched. Oh, and goodness, the table goes on further, sorry. So also epilepsy, polyneuropathy and peripheral neuropathy, multiple sclerosis, CNS infections, meningitis, encephalitis, ALS, so amyotrophic lateral sclerosis, intellectual disability, and then whether the patient was on metformin or not, whether the patient was on a sulfonylurea or the meglitidine classes or not, whether the patient was on a DPP-4 agent or not, whether the patient was on a thiazolidinone drug or not, whether the patient was on a glucosidase inhibitor or not, whether the patient was on insulin or not, as I've mentioned, whether the patient was on an antidepressant or not, and whether they were on an anticonvulsant or not. So all of those factors were propensity matched, which means that the percentages between the two groups were almost identical. So that's a way of trying to get around potential biases by the fact that this was a retrospective cohort study as opposed to being a prospective randomized controlled trial. So there's fundamentally going to be more biases in a retrospective observational type study compared with a prospective experimental design study. But one way that the authors tried to minimize those biases was by doing this propensity matching so that all of these confounders that they prospectively hypothesized could be confounders were equal between the two groups. Importantly, the only factor that wasn't equal between the two groups, and this is a design feature of the trial itself, is the number of oral anti-diabetic drugs that the patient was on. Because by definition, the SGLT2 inhibitor group were on about one additional medication compared with the other group because they were on an SGLT2I inhibitor, which is an anti-diabetic drug, and all the other anti-diabetic drugs were controlled for, so they had to be on about one more drug. So, was this a smart choice? When I first read the paper, I actually thought that this was actually quite problematic because what it means is that the patients in the SGLT2 inhibitor group are all in total on about one extra oral anti-hyperglycemic agent compared to the control group, indicating that those patients are being more aggressively managed, which could imply that they've just got worse diabetes that required more medication to get under control. Or it could imply that they didn't have worse diabetes, they were just being appropriately more aggressively managed by their treating physician. And so maybe it's just their diabetes is being better managed overall and they're on more drugs overall. And so maybe the primary outcome, whatever that turns out to be, whether that's an improvement or a worsening or no change, but whatever the result turns out to be, maybe that would be influenced by the fact that the intervention group was on one more medication than the control group. The downside in terms of if you didn't have this factor and if the patients in both groups were on the same amount of medications, then that would mean that they would, by definition, not be able to do propensity matching for all the other classes of anti-diabetic medication. I will mention that the methods section does state that the bioclinical parameters, including glycemic control, were also used in the propensity matching. That wasn't actually included in the table, but it is written in the text that glycemic control was also used in the propensity matching. So what that means is that the two groups had similar glycemic control. So provided this is indeed the case, that then tells us that just because the patients in the SGLT2I group were on one more medication than the control group, their actual glycemic control was the same between the two groups. And I do think that that largely circumvents this potential big problem because if their glycemic control is about the same, then that strongly indicates or implies that the control or the quality of the management of the diabetes is about the same between the two groups because their glycemic control is the same. And also the micro and macrovascular complications in the patients is also propensity matched and the same in the two groups. So I think this is a potential issue. That's why I put it in red if you're watching in the video. But I do think that they have circumvented this problem by controlling for glycemic control between the two groups. So let's move on. The primary and secondary outcomes. They had relatively short follow-up periods, so a mean of 2.8 years, so just shy of 3 years. And you have to take that into consideration against the pathogenesis of neurodegenerative conditions. So for some studies, a follow-up time of 3 years might be a really long follow-up time. In lots of epilepsy trials, the follow-up period is only 12 weeks. And then there might be an open label extension study which is attached onto it, which might go for a year or 18 months or so. So compared with other studies, a follow-up period of a mean of just shy of 3 years doesn't seem that short. But when you consider the pathogenesis of neurodegenerative conditions, it can take up to 20 years for some neurodegenerative conditions to develop, especially if you're thinking about the preclinical stages and then the clinical stages. So Alzheimer's disease, Parkinson's disease, they can be brewing and brewing and brewing for decades before they even manifest, and then they can manifest at different rates. And some patients can then have manifest symptoms for decades and decades as well. But despite that, what did the study actually find? That's what you're all here to find out. So the SGLT2 inhibitor group did do significantly better, statistically speaking, in all of the primary and secondary outcomes with reasonably substantive effect sizes. So I'll say that again. The SGLT2 inhibitor group had a statistically significant improvement compared with control in all of the primary and secondary outcomes, and the effect sizes were fairly substantive. So it's going to be a bit difficult for me to read out all these results in an audio podcast format. And I'm not going to read out every number in this table. So if you're watching on video or if you're not, you can have a look on the video when you get a chance and have a look at this table, or you can look at the paper if you're interested. but it has the numbers and the p-values and the confidence intervals here. Some of the key numbers to be aware of is that the incidence rate, so you'll remember that was measured in events per 10,000 person years, was for Alzheimer's disease about 40 for the SGLT2I group, and significantly higher than that, so about 64 in the control group. Whereas for vascular dementia, it was about 11 in the SGLT2I group and about 19 in the non-users group, in the control group. For Parkinson's disease, it was 9 in the SGLT2 inhibitor group and about 14 in the control group. For the compound or composite all-cause dementia, it was about 41 in the SGLT2 inhibitor group and about 66 in the control group. And for the composite outcome of all-cause dementia and also Parkinson's disease, it was about 48 in the SGLT2I group and about 76 in the control group. And the p-values for all of these were less than 0.05. And in fact, they were all at or less than 0.001. And along with that, the lower end of the 95% confidence interval was always not crossing 1 by definition, if you remember your fundamentals of statistics. So they also reported the findings in terms of incidence, and then they provided crude hazard ratios and also adjusted hazard ratios. And you'll note that the adjusted hazard ratios were similar to the crude hazard ratios, given that the adjustments were made for all of the same confounders that were already matched during the propensity matching system that I spoke about previously. And we already know that all of these factors were balanced between the two groups, so then adjusting for the two wouldn't be expected to have a significant change, so we don't really expect the adjusted hazard ratios and the crude hazard ratios to be that different. And actually talking about the hazard ratios, the way that they defined this was they used a hazard ratio of 1 for the control group by definition as a reference, and then it looked at what was the hazard of having the outcome for each of these condition primary outcomes if you were on an SGLT2I inhibitor. And for irrespective of whether it was a crude or an adjusted hazard ratio, the number was always lower, so less than 1.00 in the SGLT2I group. And that gives an indication furthermore of the effect size. So typically across the board, the hazard ratios were about 0.6 to 0.7 roughly, or the adjusted hazard ratios were similar, slightly higher. I thought it was quite interesting and impressive that the SGLT2I inhibitor group had such a significant relative risk reduction, so such a significant lower hazard ratio that was demonstrated in this study, despite the what I consider to be a relatively short mean follow-up duration of just shy of 3 years, given the time course of the pathogenesis of neurodegenerative conditions, as I spoke about earlier. So in a sense, that makes the findings even more impressive. So this slide demonstrates some of the same findings, but demonstrated as cumulative incidence curves. And it demonstrates again that the cumulative incidence of Alzheimer's disease, vascular dementia, Parkinson's disease, and all-cause dementia as time progresses was higher for the control group and lower for the patients on the SGLT2 inhibitors. So they got less of these diseases as time went on, as we would expect. And the same is true of all-cause dementia and Parkinson's disease, so that composite group. Now, they did some further sensitivity analyses, and what this means is that they looked at the dose effect, so I talked about that earlier in part. So they found that increasing duration of SGLT2I use was associated with reduced risk of neurodegenerative diseases, and that's, they say, further evidence of a causal relationship. They also found that thiazolidinone use was not associated with benefit, whereas SGLT2I inhibitor use was associated with benefit when the two were compared in a head-to-head comparison. They then further performed assessment that was limited to patients who had national health screening data including all the biochemical variables required, so as to balance for glycemic control, and it continued to demonstrate consistent benefit for the SGLT2I group. And I think that's really important given that concern I raised at the beginning in regards to the SGLT2I group having one more medication and therefore plausibly maybe they would have better glycemic control, but this showed that even balancing for that, that wasn't the case. And there was also found to be a synergistic benefit of SGLT2 inhibitor use and metformin compared with any other two oral hyperglycemic agents in combination. So that's saying if a patient needs to be on two drugs, then in terms of the best outcome from a reducing neurodegenerative diseases perspective, the combination of metformin and an SGLT2I inhibitor was the best combination to be on. So these are the tables demonstrating the results that I just mentioned. I won't go through all the numbers in the interest of time, but this first table looks at the risk of dementia with cumulative exposure to SGLT2 inhibitors. Sorry, the risk of dementia and Parkinson's disease, I should say, and the risk reduced with the longer duration of use. So comparing no use with more than 6 months, with more than 12 months, with more than 24 months, for each of the primary outcomes. So Alzheimer's disease, vascular dementia, Parkinson's disease, all-cause dementia, and composite all-cause dementia and Parkinson's disease, they all had less incidence with increasing duration of SGLT2 inhibitor use, and everything was statistically significant. So I thought that was a fairly impressive finding that they were able to demonstrate. They then did a head-to-head analysis of the SGLT2 inhibitor use and thiazolidine ion use, and they found that the former had a benefit, whereas the latter did not have a benefit in terms of risk of dementia and Parkinson's disease, but I won't go into all of the details here. So even though this seems to be a minor supplementary table that was included in the supplementary component of the publication, I think this is actually one of the most important tables in the publication because this is what addresses that key concern that I had initially. So this is looking at the fasting plasma glucose levels between the two groups that have been propensity matched for various characteristics, but the propensity matching, it said in the text, was also propensity matched for fasting glucose, but then it also later on said that that was actually evaluated through sensitivity analyses. So it's a little bit unclear as to exactly what they did there. But in any case, what this table demonstrates is that the mean fasting plasma glucose between the two groups was almost identical. So in the control group, it was 150 exactly, measured in milligrams per deciliter, whereas in the SGLT2 inhibitor group, it was 150.4, so almost identical. The standard deviation was a bit larger for the control group at 57.5, so the spread was a bit bigger, whereas in the SGLT2 inhibitor group, it was 47.6. But in any case, the mean was essentially identical. This table here just demonstrates some of the other parameters that they looked at from the national health screening tests at a biochemical level and also at a comorbidity level. And again, I don't have time to talk through all these, but if you're interested, you can look at this table to see where there was or wasn't a statistically significant difference. But I will say that looking through all of the parameters they looked at, there was no meaningful difference at all, really, between any of these variables that they looked at in between the two groups. So the two groups really were very, very well balanced. And it goes on here further, demonstrating the same finding. Supplementary table here just demonstrates the same primary outcome measures, but evaluated according to the subset of patients who had enrollment in the national health screening and at least one additional follow-up national health screening test. And it demonstrates the same findings as the original primary outcome findings, but with even more impressive primary outcome measures in terms of the hazard ratio reduction. I'm not entirely sure as to why the numbers look more impressive here. I suspect that because these patients were those who underwent at least one additional follow-up screening test, the overall follow-up of this population subset may have been longer than for the population as a whole, and so there may have been more dose effect in terms of benefit from the SGLT2 inhibitor. Perhaps that's just me speculating, but that's interesting nonetheless. And this table here just demonstrates that the combination of SGLT2 I inhibitor plus metformin compared with any combination of any two anti-hyperglycemic agents apart from that specific combination did the best in all of the primary outcome measures. So in Alzheimer's disease, vascular dementia, Parkinson's disease, all-cause dementia, and all-cause dementia and Parkinson's disease across the board with p-values of less than 0.001 in each case for the crude hazard ratios and also statistically significant, although not quite as impressive hazard ratios for the adjusted hazard ratios, but still a very consistent across the board finding that they demonstrated. Now, moving to the subgroup analyses, basically what they found was that all of the socio-demographic, comorbidity, and other concurrent medications that they looked at were not associated with a significant difference in the outcome amongst patients in the SGLT2 I inhibitor group, although I would say that age was marginal. So what I mean here is that for the parameters such as sex, male versus female, the comorbidity index, the presence or absence of diabetic neuropathy, nephropathy, or retinopathy, the presence or absence of cardiovascular disease, stroke, heart failure, arrhythmia, hypertension, dyslipidemia, metformin or no metformin use, sulfonylurea or metaglutamide use, TZD use, that word I can never pronounce. None of those demonstrated a difference between the two of them in terms of the hazard ratio. The only borderline finding here was age. So it was not statistically significant, but there was a slight finding that patients who were greater than or equal to 65-year-olds had a higher hazard ratio, so a lesser reduction in hazard ratio compared with younger patients, so less than 65 years of age. So younger patients seem to do better than older patients in terms of the development of neurodegenerative conditions within the follow-up timeframe, which is, of course, a completely expected finding because older people are more likely to get neurodegenerative diseases in the first place, and the follow-up period was not an infinite follow-up period. So within the follow-up period, it's more likely that you would develop a neurodegenerative disease if you're already older to begin with. That's just common sense, really. That's an expected finding. So we can take a deep breath and think about, what does this mean? How can we conclude from this study? Well, what do the authors say to begin with? Well, to quote, they say, "This study provides class 2 evidence that SGLT2 anti-diabetic drugs decrease the risk of dementia and Parkinson's disease in people with diabetes." In terms of discussion points raised that we haven't already talked about at length, the one main thing that they do talk about is they speculate on the potential biological plausibility of this relationship. And I think it's worth going into what the biological plausibility may be. I mean, this is all speculative in regards to the underlying pharmacopathological mechanisms by which these medications may actually help. But let's go through what they suggest. So they say that, and quoting, type 2 diabetes causes cerebral vascular insufficiencies as consequences of endothelial dysfunction. For non-vascular mechanisms, insulin resistance may explain the pathophysiologic link between type 2 diabetes and neurodegeneration. Cerebral insulin resistance induces an accumulation of toxic proteins. Insulin resistance can also cause brain cellular energy deficiency, resulting in mitochondrial dysfunction, promoting oxidative stress. Increased oxidative stress in the brain leads to neuronal cell damage and neurodegeneration. Secondly, they say that the action of SGLT2 inhibitors mimics a fasting-like metabolic paradigm by inducing glycosuria and urinary caloric loss, and this may partly underlie the neuroprotective potential of SGLT2I inhibitors. The glucose energy deprivation by the SGLT2I inhibitors suppresses mTOR signaling, which may recover brain mitochondrial function. In addition, restoration of the mTOR dynamic by SGLT2I inhibitors enhances autophagy and lysosomal function, reducing accumulation of toxic proteins and neuronal loss. Thirdly, they speculate that fasting mimicry by SGLT2I inhibitors augments ketogenesis and ketone bodies function as antioxidants and alternative energy substrates for glucose in the brain, which alleviates neuronal metabolic dysfunction. Fourthly, they speculate that SGLT2 inhibitors may directly modulate SGLT proteins expressed in central nervous system tissue. And finally, and fifthly, they speculate that several types of SGLT2 inhibitors exhibited a function of inhibiting acetylcholinesterase in the brain, which corresponds to the main mechanism of dementia drugs. So, just to summarize that, the speculated or hypothesized mechanisms by which it may be biologically plausible that SGLT2 inhibitors have a direct beneficial effect in terms of preventing or reducing the risk of Parkinson's disease and dementias, independent of their effect on just glucose lowering as an anti-diabetic drug, are five things. Firstly, their beneficial effects in terms of effects on insulin resistance and the flow-on effects that that has for improved mitochondrial function and reduced oxidative stress. Secondly, they're mimicking a metabolic fasting paradigm through glycosuria and urinary caloric loss, and then the effects that that has on suppressed mTOR signaling pathways and therefore improved mitochondrial function and restoration of autophagy, and therefore reducing the accumulation of toxic proteins and neuronal loss. Thirdly, through augmentation of ketogenesis and ketone bodies directly functioning as antioxidants and as serving as substrates alternative to glucose for metabolism in the brain. Fourthly, through direct modulation of SGLT proteins expressed in the central nervous system. And finally, some SGLT2 inhibitors having a function similar to acetylcholinesterase inhibitors, which of course is the main mechanism of action of many anti-dementia drugs. In fact, most of the conventional anti-dementia drugs, such as donepezil. As we mentioned earlier, it was found that in the subgroup analysis there was a non-significant trend towards greater benefit in younger patients, which is unsurprising given the duration of follow-up. And also it makes more sense because you're getting the benefit in early before the neurodegenerative pathogenesis gets too far along, at least plausibly. So what are the limitations of this study? Well, we've already spoken about the limited follow-up period relative to the duration of the pathogenesis of dementia and neurodegenerative diseases, and it could therefore make it more likely that SGLT2I inhibitors delay the onset of dementia rather than preventing it completely, and therefore longer-term efficacy studies are required. And this is a really good point. It's also important that with longer-term studies, there could be an introduction of a survival bias. In fact, that would be inevitable. So what that means is patients who are treated with SGLT2I inhibitors may live longer and therefore be more likely to eventually develop a neurodegenerative disease just by virtue of the fact that they're living longer to begin with. So that would be another challenge. Other limitations include that the study did not address the question of whether early use of SGLT2I inhibitors prior to when drug therapy would usually be initiated for the diabetes itself has any additional benefit in reducing the cumulative incidence of neurodegenerative diseases. HbA1c data was not available for balancing in the propensity matching or in the secondary statistical analysis of the results. The study was conducted with a post hoc design, so pre-specified analyses could not be performed. Now, this is a reasonably large problem. You don't ever want post hoc studies because that makes the study liable to p-hacking. That being said, the study was prospectively registered with a study protocol, so it wasn't completely post hoc, but it is problematic. And finally, the study was in a single Asian ethnicity, South Korean patients, so it potentially restricts the generalizability of the findings. So, this is the last substantive slide in the talk, which is what are my thoughts about this? Well, yes, there were a few limitations of the study, which I won't harp on about because I've already spoken to them at length. But I think that on the whole, the study did demonstrate reasonably compelling evidence for both a statistically significant and a clinically significant reduction in the incidence of neurodegenerative diseases developing during the observation period of the study with SGLT2I inhibitors in patients with type 2 diabetes. And that's in addition to the already established cardiac benefits and renal benefits. So I think that all other things being equal, it does give at least some evidence, and I think reasonably compelling evidence, to consider prescribing an SGLT2I inhibitor for your patient with diabetes, perhaps as a second line agent after the metformin, rather than choosing a different option in terms of oral anti-hyperglycemic agents where all other things being equal, there's no major difference between the outcomes in terms of diabetic control and flow on benefits for other end organ systems. So if you're stuck between choosing between a DPP4 agent and an SGLT2I agent, for instance, and there's nothing really swaying you one way or the other, and they're both acceptable second line agents, and you just can't choose which one you're going to choose, then, well, this study shows that as observational retrospective data, so not prospective, not experimental data, but at least a large population-based, registry-based data set with close to 400,000 patients in it, that the SGLT2I inhibitors were associated with, correlated with, we can't really draw causation, but strongly correlated with a reduced incidence of neurodegenerative diseases. For me, at least, that's at least a reason to consider prescribing the SGLT2I inhibitor as opposed to the alternative oral anti-hyperglycemic agent. And the study also showed that there was a dose effect which strengthens the case for causality. And it also looked at the combination of an SGLT2I inhibitor and metformin, and it found that that was the sweet spot in terms of combination therapy with two agents. So I think that's interesting. I do. And I think that will have an impact on my prescribing practice into the future. I'd be interested to learn whether in the future there's ever a role for an SGLT2I inhibitor as a first line therapy, or whether it still really is the case that metformin forms the backbone of therapy as the first line management. And that's something that wasn't looked at in this study, but I'd be interested regarding that in the future. So I'd really love to hear what you think. So please let me know in the comments. And interestingly, the first audience that I presented this journal club to at a hospital that I was working at, the audience weren't quite as swayed by the paper as I was. They said to me that they didn't really think that this study would influence their prescribing pattern in regards to choosing or not choosing an SGLT2I inhibitor when they're prescribing for diabetes. So they were a tough crowd. They were a tough audience. But I'd love to hear what you think. I'd love to hear if you think the way that I'm thinking or whether you see it differently. So that's all I had for today. Thank you so much for tuning in. I hope that you found it valuable in terms of really going through the process of critical evaluation of a journal paper and thinking, what are its strengths? What are their weaknesses of the paper? How can it be applied to my clinical practice, if at all? And also learning a bit about the time course of neurodegenerative processes and the different options for treating diabetes, which isn't a direct neurologic problem, but it comes up in neurology all the time. We have patients in neurology who all the time have diabetes, especially in stroke cohorts and other cohorts. So it's something that we need to know about as physicians. So that's it. Please like, comment, and subscribe. Visit our website, rneurologyeducation.org, for all of our media formats and additional content. Find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms at the domain at rneurologyeducation, or email us at contact@rneurologyeducation.org with any questions or to subscribe for updates for when new content is released. From cortex to curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.